Hi friends, so continuing with my lecture series on integrated medicine, I'm going to take up an important topic today that is about influenza or flu. I'm going to talk about H1N1 2018 updated guidelines. So point number one, MCQ number one, whenever we get a suspected case of influenza or flu or H1N1, we need to categorize the patient. So first of all, we need to do the screening of the patient, and we need to put them into categories. So we can have three categories: category A, or we can have category B, or we can have a category C. So category A is pretty simple. It is mild fever. What do you mean by mild fever? Any case of mild fever which starts within 48 hours and the temperature has to be less than 38 degrees centigrade. Within 48 hours, less than 38 degree, we categorize it as mild fever plus or minus sore throat. That will be put up as category A. In category A patient, please remember there is no testing to be done and there is no treatment to be taken up. Only symptomatic treatment has to be carried on for this particular case, category A. In category B, we might have category A patients with high grade fever. What is high grade fever? Fever which is high grade. Fever which is high grade is more than 38 degrees centigrade. Or we can also have plus, there could be high risk patients. So this is where the MCQ people will strike you. They'll give you a clinical scenario. 28-year-old male coming to an OPD with these thing. What is the category? So please remember, this could be your potential MCQ. What are the cases which are put under high risk? The first is we need to put all the pregnant females under high risk. Second is any patient with any comorbidity. What are the comorbidities that we can think of? We can think of any liver disease which is of serious nature, cardiovascular disease, we can have lung disease, we can have CNS involvement, or we can have cancer, any patient with concomitant cancer or case of HIV. All these are categorized as comorbidities as far as influenza is concerned. In case of age more than, please remember, 65 years. This is the most commonly asked MCQ, so I'm going to highlight it for you. This is a very frequently asked question. Age more than 65 years we categorize as category B, with or without fever. And then we have another important thing, that is long-term patients on long-term any steroid or cortisone therapy. They are also categorized as category B. So what do we do to them? In high-risk cases, MCQ can be asked that please remember, in high-risk cases, there is no testing done. You do not need to send the sample. You directly, in case of any epidemic, we directly treat them with oseltamivir. Oseltamivir is the drug of choice for influenza, so there is direct treatment for oseltamivir. No immediate testing needs to be done. So in cases of fever, patients only with fever, you need to do them. You need to do a testing, plus you need to treat them. So plus or minus treatment if the test is positive, but testing is mandatory. Please remember, in this the testing is not mandatory at the first level. You directly need to start with oseltamivir, especially in cases of flu season. In category C patients, what are category C patients? Please remember, category C is category A patients plus any red flag symptoms. What are red flag symptoms? The red flag symptoms could be hypotension, patients suffering from hypotension. Second, breathlessness, or shortness of breath, blood in sputum, that is hemoptysis, or they could be cyanosis. Cyanosis could be central or peripheral, whatever it is, cyanosis is a red flag symptom. In cases of children, please remember, I would like to put an asterisk marks, and in cases of children, the red flag symptoms are, they have a different red flag symptoms. In children, there is shortness of breath, then there is convulsions, And this is where the maximum frequently asked question, I'll put a star mark over here, frequently asked question, the patient was having somnolence. It's all somnolence, it's all red category, red flag features. And then we also have inability to feed. Inability to feed. These are all red flag symptoms in case of children. All these are put up as category C patients. In them, we need to test them. You know testing is required, but you just take the sample and you directly send it for treatment oseltamivir, especially in cases of flu season. So these are your category C patients. Next, question number 2. I would also like to discuss another important point. That's how we screen patients into 3 categories. Whenever we get a patient of suspected flu, especially in a flu season, we need to assess them for ARDS in case we get category B or C patients. So we need to assess them for acute respiratory distress syndrome. The ARDS suspicion has to be based upon the partial pressure of oxygen in the artery divided by the FiO2 fractional inspired oxygen ratio. So in short, I can refer it as PF ratio or PaO2 divided by FiO2 ratio. If the PaO2 by FiO2 ratio is more than 300, that means there is, please remember, if more than 300, there is no respiratory failure and the patient does not need any intervention from ARDS point of view. But in case it is less than 300, now we need to see whether we need to give a ventilatory oxygen support or a ventilatory support, yes or no. So in case it is from 200 to 300, it is known as mild ARDS. In case it is from 100 to 200, all these I'm talking about is the partial PaO2 divided by FiO2 ratio. 100 to 200, that is known as moderate ARDS, and less than 100 means severe ARDS. So that is a classification for ARDS you need to remember. It is simple based on PaO2 divided by FiO2. In certain cases where the ABG analysis is not there, in those cases we can even take the saturation of oxygen SaO2. If it is more than 90, we need to give them nasal oxygen. If the saturation, please remember, if the SaO2 is more than 60 but less than 90, we can always try more than 60. If the patient is maintaining, we can try for non-invasive ventilation support. But in case the patient is having SaO2 less than 60, then we need to have an invasive ventilation support. There could be a difference of opinion between various hospitals that if the SaO2 is more than 60, right? People can also go for invasive ventilation support, but recent studies and the guidelines says that non-invasive has much more better prognosis as compared to an invasive ventilatory support. So that's the reason if it is more than 60 and the patient is able to sustain on more than 60 SaO2 with non-invasive ventilatory support, the guidelines say that you need to continue with the non-invasive ventilatory support. So in case the patient is not able to sustain, in those cases we need to give invasive ventilatory support. I would also like to point out that you need to give ventilatory support. What are the patients on whom you are going to give a ventilatory support? The ventilator support is needed to in such cases of influenza or flu where the PaO2 we already discussed divided by FiO2, just now we discussed, is less than 300, this ratio, or if there is evidence of bilaterally pulmonary infiltrates along with pulmonary plus pulmonary edema, along with pulmonary edema. And please remember, the patient does not have evidence of left atrial hypertension. So in these 3 cases have to be there whenever we are going to give a ventilatory support. So that's an emergency procedure where you need to assess for the level of ARDS for the suspected case of influenza or flu that comes to your hospital, OPD, or the clinic. What is the treatment? Next topic, question number 3. What is the treatment we are going to give? The drug of choice for influenza is oseltamivir. Oseltamivir. Please remember, in case of upper respiratory tract involvement, URTI infection, the drug of choice is oseltamivir. It is given as oseltamivir. It is given at the rate of 75 milligram BD dose for 5 days. In case of the symptom persist, in case of persistence of symptoms, even on day 6, now you need to extend this oseltamivir to another 5 days for total of 10 days. So total of 10 days we extend in case of URTI not responding even on day 6. In certain cases where you have upper respiratory tract involvement plus you have a tracheal involvement or a lower respiratory tract involvement where you have both in cases of flu, now the drug of choice is again oseltamivir but with a different dosage, that is, it is given at the rate of 150 milligrams double dose BD into 10 days directly. So that's the dose you twice daily we give oseltamivir 150 milligram. Other drugs which can be given in cases of flu which have been tried is zanamivir and peramivir, which can be given but which are not approved for use in India. In India we are using oseltamivir as a standard drug. Along with oseltamivir, we are also supposed to take care of the IV fluids. Usually in cases of ARDS, the patient is usually kept dry, not too much of IV fluids is given, but IV fluids is an important component you need to remember. Third, any case of blood or blood components have to be catered. Blood components have to be catered for. Next is antibiotics, broad spectrum antibiotics. Usually the hospital, depending on the hospital protocol, but the guidelines say that we are supposed to give azithro or amoxicillin in usual cases of flu which are admitted to the hospital, but in cases where we are giving invasive ventilatory support, then high-end broad spectrum antibiotics as piperacillin or meropenem is indicated, is the drug of choice. Meropenem is the drug of choice for antibiotics. Then of course these are like supportive therapy you need to give for H1N1, that is low dose hydrocot therapy. Hydrocot at the rate of 50 milligram 6 hourly is usually beneficial to the patient because it relieves a kind of bronchospasm, and it also prevents a patient from getting into the septic shock which probably they could have been. Next is, you would also like to talk about the bronchodilators, bronchodilator, and maybe mucolytics. Alongside, we need to give nutritional support and maybe prophylaxis from DVT prophylaxis, because the patient might be long-standing like on ventilator support. In those cases, we might need to give them DVT prophylaxis. So alongside that would be all for the patients who are in the hospital. But from preventive medicine point of view, we can also think of H1N1 vaccines. So if you want to know about the H1N1 vaccines, we probably have two types of vaccines available. One is inactivated H1N1 flu vaccines. So inactivated flu vaccines or influenza vaccines, we can write it as inactivated influenza vaccine. These can be egg-based or non-egg-based. Egg-based can be like trivalent vaccine. So this can be your potential question. You need to remember that the trivalent vaccine contains 3 strains. It contains a Michigan strain, Switzerland strain, and a Colorado strain. We can also have another egg-based quadrivalent vaccine. Quadrivalent vaccine alongside Michigan strain, Switzerland and Colorado strain, we also have a Phuket strain. So that is a quadrivalent vaccine, and this is the quadrivalent vaccine which is approved for H1N1 flu vaccine, flu shot for flu vaccine for year 2019 in the southern hemisphere. These are also known as the hemisphere southern hemisphere flu vaccine. And another is a non-egg based vaccine. This non-egg based vaccine is Singapore strain vaccine. This is also approved for year 2019, and both these vaccines are used according to WHO for H1N1. Please remember, for H1N1 we also have another vaccine. So both these are like inactivated influenza vaccine, which could be egg based or non-egg based. We also have another type of influenza vaccine, that is a live vaccine. It is a live attenuated vaccine, influenza vaccine. This live attenuated influenza vaccine is a nasal spray. The contraindication you need to remember for this nasal spray vaccine is it is contraindicated in cases of pregnancy. Of course, because it is a live vaccine, it is also contraindicated in immunocompromised state and in people who are age more than 50 years. So age more than 50, all these are contraindications of these live vaccines. I would also like to bring out another important point that the WHO says that the utility of flu vaccine, it is indications. So the indication of flu vaccine, it is indicated in case of pregnant females. It has a very strange kind of vaccination policy that in cases of flu, the most priority for flu vaccine, flu shot has to be given to pregnant female, followed by pregnant females. We might vaccinate all people who are age more than 6 months, because this inactivated vaccine is given indication is age more than 6 months, who have any comorbidity. So in those cases, that will be our priority number 2. The priority number 1 is for pregnant females. Priority number 3 is for adults. It's a different, I told you, it's a different kind of prioritization. The adults would be like 15 to 49 years. After these adults, we are going to vaccinate all the healthy children age 6 months till 15 years. After healthy children, we are going to vaccinate all the healthy adults who are age more than 49 years but less than age more than 49 years but less than 65 years. And in the last, we have the priority for vaccinating senior citizens or the healthy adults who are age more than 65 years. So that's kind of a strange prioritization. That's how we actually vaccinate the general population. That is the prioritization system or strategy for flu vaccines or influenza vaccines. So these are like 2 or 3 important things you would like to remember about the influenza vaccine and the use of this vaccine. So now I would like to take up another important point about that. Finishes the topic on influenza, what you need to know for your entrance exam point of view. I would like to take another important point about the recent advance. So just recently we have a new drug, that is baloxavir marboxil, which is FDA approved. This is an oral drug which is FDA approved for age more than 12 years. So it is FDA approved for age more than 12 years. Please remember that the baloxavir marboxil is basically a drug which acts on inhibition of the viral proliferation. So I'll just have a small schematic for how this virus acts. So if there is a virus like this which has a RNA material into it, and these are the receptors on the virus, this virus is going to attack the host cell. So in the host cell, it goes and attacks the host cell. So in the host cell, there is this receptor. There is this receptors with the viral genome, DNA genome, RNA particles, and then it actually enters into the host cell using the hemagglutinins. So using the H receptors, hemagglutinin receptors, they do the first function, that is the entry of the organism. Once they have entered into the organism, they will undergo uncoating of the virion particle, and after uncoating, this virion particle actually enters the nucleus of the cell. Now within the nucleus, once it enters into the nucleus, the viral endonucleases will act and attach to the mRNA molecules in the nucleus of the host cell, which will produce new viral genetic material. So there is actually a viral replication which will take place. So now this whole thing moves out of this new genetic material moves out of the nucleus, and then there is assembly of and of the particle and budding of the virion, and then there is viral outside this host cell. Now there is viral particle release. So I would also like to take this opportunity of telling you that if this is the host cell, you have what all mechanisms. You have first level, that is the entry. Second is uncoating. Third is entry of the nucleus. Fourth is viral endonucleases attached to the mRNA. Fifth is assembly and the budding. And last section would be viral particle release. So I would like to inform you that we currently do not have any entry inhibitors for the virus particles, but for uncoating, there are certain drugs which are available. Certain drugs which are M2 ion channel inhibitors. These M2 ion channel inhibitors are what are the adamantins or the amantadine. Example for this drug, these are adamantins, which are amantadine, or we have another drug that is rimantadine. I would also like to inform you that at this level, at the viral particle release, using the neuraminidase enzyme, there are neuraminidase inhibitors, which are your drug of choices for influenza, that is oseltamivir, or we have the zanamivir. So these are primarily the FDA approved neuraminidase inhibitors. Please remember that the M2 ion channel inhibitors, these are not FDA approved. They are currently not FDA approved drugs. So now we have this new drug, that is baloxavir marboxil. This baloxavir marboxil attacks or functions at this junction. It inhibits the cap dependent endonuclease enzyme, and because it inhibits this cap dependent endonuclease enzyme, this viral proliferation is inhibited, and it is a wonderful drug, and it is FDA approved. This drug is what is cap dependent endonuclease inhibitors. These are what are baloxavir marboxil, which is a novel drug which is approved for use in influenza. So this is the point where the recent advance is there for influenza, which has been included as a part of the treatment strategy for high-risk cases. So I would like to thank you for watching this video and wish you all the very best for your upcoming exams. Thank you so much.